Okay, diving in. So we're talking about health disparities and deaths of despair this morning, something I've wrote about for many years as a reporter, and a subject that's really near and dear to my heart. It's been almost a decade since this study came out that put the idea of deaths of despair out there in the country. The Case and Deaton study from Princeton that found white men in particular were dying in midlife, largely due to suicides, drug overdoses, and alcohol issues. And I wondered from all of you, we're like almost 10 years after that study came out, where do things stand in your minds? Like, what's going on with deaths of despair 10 years after we first heard this phrase?
Do you want me to go?
Sure, Beth.
Yeah. So it's just gotten worse. So every time the numbers come out, they're worse. I'm talking about the opioid deaths. And if you go back to the introduction of OxyContin in 1996, we've lost north of 1 million people just to opioids. And I've interviewed Deaton and Case and appreciate their work, and I'm seeing it on the ground with the reporting I'm doing now in rural Ohio, where mental health emergencies are now, and suicide, are now overshadowing opioid deaths.
Oh, wow.
And a lot of that is because it's meth, which isn't quite as fatal in some cases. But their newer paper, which I'm finding very relevant to what I'm doing now, is showing that the number one protective factor against the death of despair is a 4-year degree.
Yeah.
And having grown up poor in rural America and being the first in my family to go to college, I went fully on Pell Grants, and it paid the full freight. And we have basically taken that away, going back to 1980. We've taken that away. And so what I'm seeing now is just basically a 3.0 opioid crisis, a third generation of folks who are raised in this,
right.
Kids who have seen their parents overdose or have lost a parent or their parents in and out of jail. And I think when we take away slowly, without hardly any discussion as a nation about that, we take away people's hope. And so I'm not surprised when the numbers come out. We have an 87% treatment gap, by which I mean only 13% of folks with OUD are able to get evidence-based care. So we're still not matching the treatments to the urgency of the crisis, in my opinion.
And I'm curious, in terms of treatment and the fact that all these years in and all these years of research telling us what the answer is, what barriers remain in your system, Doctor? What are you seeing in terms of just the difficulties getting people into treatment?
Of course, every problem is like multifactorial, but I would definitely say that in some of the communities that we serve, there's still some stigma attached to it, for sure. And part of that, let's remember that when we had issues with opioid use and opioid addiction that started in the Black community, it was criminalized. And whether for use, for possession, anything, like people lost their lives, they were in jail forever. It built the prison complex. And so, now it's a different thing. It almost seems like, when it hit mainstream white America, then it was the compassionate approach. Oh, this is really a disease. It's not anyone's fault. We don't need prison terms. We need therapy. And so there's a new look to it now, but a lot of people are coming out of where family members or loved ones were told that they were less than, that they were criminals, and people are still in jail finishing out some of those sentences. So it's really trying to come out of that mindset and say, oh no, but now there's help. It's a different way to look at it, and some of the people who have kind of felt the brunt of what the original approach to it was,
Yeah.
are still trying to convert to a new set of thoughts.
Right. Takes a really long time, generations maybe even.
Yeah. But we try to make resources available, try to do a lot of education. We have social services arms at Sinai, Chicago, which make Narcan teaching. First of all, people need to understand, what it is, that it's available, and then how to get it. Medication-assisted therapy. Try to make sure that we have those services available.
Right. I'm surprised to hear, in a way, although really it's not surprising, but to hear you say stigma still exists. And I assume you're talking about methadone and buprenorphine treatment in particular for
or just
opioid
even
use
having
disorder?
The problem, even having, having a substance abuse, condition, disorder, being able to come forward with that and ask for the help, there's still some thoughts that, something's wrong with you if you're in this situation. So a lot of education, a lot of destigmatization is still necessary.
Right. Do you see that as well, Dale, in Portsmouth, Ohio? What are you seeing in terms of people seeing treatment for buprenorphine and methadone treatment in particular for opioid use disorder as stigmatizing, or even as like sort of a weak approach versus, the old cold turkey methods?
To the doctor's point, stigma kills just as much as addiction does, because people are afraid to seek services based upon judgment passed along to them. And I used to be a big part of that negative stigma towards people wanting help. I'm born and raised in Portsmouth. It's one of the hardest hit areas in the country when it comes to the opioid crisis. And basically what we mean by stigma is, why can't you get your shit together? Right? That's what, I'm not an addict, why can't you not be an addict? And if you trace that back, and this is, I'm so happy to be here with Beth, her work is greatly discovered how we got there. And basically, that was a Sackler PSYOP campaign. Hammer the abuser. It has nothing to do with the pharmaceutical industry that created OxyContin. It's the abuser who's taking it, and we all know that's completely wrong. So what's happened, especially in my small town, is people cast negative dispersions of judgments upon the folks who are addicted, just like I did. And it wasn't until
that's still happening, Dale?
Oh yeah,
Oh, yeah.
100%. And it needs to be an awareness campaign, right? Like, that's not Tony the addict, that's Tony your cousin. That's Tony the former veteran. That's Tony the guy who used to deliver your pizza. And what has happened to him in his life has led him to where he's at now. And so basically we can continue to cast judgment on him, or we can try to help him.
Mm-hmm. And to that end, tell us a little about the Portsmouth method that you have.
Yeah, so to understand the Portsmouth method, you got to understand the history of Portsmouth. And back in the mid-90s, a guy named Dr. Proctor created a rather highly grossing, if not malevolent, business model called pain clinics. So at the same time OxyContin was coming about, he figured out, we just do a cash for script business model. And it happened to be in an area in the Rust Belt along the Ohio River where a lot of guys who were no longer working anymore, the factory or the mill had closed down, had a lot of back problems, knee problems, shoulder problems. And what that turned into was an explosion of pain mills up and down the Ohio River that would basically cover all through Appalachia down to Florida. So Portsmouth, unfortunately, is the moniker of the birthplace of pain clinics. And I graduated in '99. And some guys were taking these pills. Fortunately, by the grace of God, I did not. And I went away for college in the military and came back in around 2007 and literally left one war zone for another. abandoned buildings, lack of hope, just a complete, utter, it's almost like soulless.
When was this, Dale, when you came back?
2007.
Yeah.
So this is right at the wave of pain clinics.
Right.
And literally, you would walk in and there'd be billboards for pain clinics up and down the highways. And I was like, what the hell is a pain clinic? And then found out more about it. But so from there, I opened up a gym as a way, essentially more of a therapeutic outlet for myself, coming back from the military. And then realized that there's a big problem in my area now, but I thought the problem was with the addict. And it didn't, and a few other entrepreneurial things happened along to about 2018 to where my good friend said he was the general counsel of a addiction treatment center called the Counseling Center. He said, hey, your gym has been instrumental in my recovery. I took this new position and I'd like for you to do CrossFit classes at the agency that I work for. And so I was like, yeah, I had no doubt it would be of some value. But the real value it had to me was I would do these classes and then sit down and have conversations with people afterwards. And completely changed my viewpoint on addiction and how people found their way into substance use. And so the Portsmouth Method is essentially, it's an ongoing community revitalization project that we want to create sober and healthy people first through fitness as an adjunct therapy to traditional counseling. And then from there, what I learned is, I was so naive to the counseling process that I thought when you were done with inpatient treatment, it's like, you're blessed, you're now sober for the rest of your life, and we're good to go, right? Mm-hmm. And it wasn't until one of the very first guys in the class, he's like, hey, he was a former Marine, he's like, man, I just want to say thank you, this has been awesome, and I'm done. So I'm like, is there a cake? Is there some sort of ceremony for you now that you're sober? And he's like, no, I'm gonna check myself into the homeless shelter, because if I go back home, I'll end up using it again.
Yeah.
And I said, shit, I don't even know where the homeless shelter is in my town. So I said, tomorrow come to the gym, I'll give you a broom and a mop, and we'll figure something out.
Wow.
And where we're at now, we have 3 small businesses that employ around 15 people in recovery, 5 of which are trainers that are now going back to the facility, coaching where they used to be clients. What is it quickly about the exercise that you think is a successful element? Oh, shared suffering. shared suffering. That's the short answer. I could go on and on about it, but and I've been listening to the fantastic conversation. It's just like rural, urban, big city, small town. It's a lack of commonality. So when you're in a group of people and you do a hard workout, no one gives a shit where you came from, who you are, what you're doing. We're all in this struggle together.
Band of brothers. Yeah.
Yeah, and then but more importantly, when we're done with it, then the best time to have a conversation is after a hard workout. And and that's a part of a little bit of cognitive behavioral therapy and counseling. But
interesting.
It's
community building, right?
Yeah.
And it's community building, right. And on that note, Beth, I'd like to hear a little more from you about some of the solutions that you talk about in your book, Raising Lazarus.
Yeah.
We've talked about how hard it is to scale these solutions, to make them something that everybody can adopt nationally, but what are some of the most successful or hopeful ones that you've seen in pockets on the ground?
Yeah.
In your journey?
Oh, thanks. That's a great question. So I was so depressed after writing Dopesick. Honestly, my main character was brutally murdered. I was just seeing barrier after barrier, nobody doing anything about it. And my husband said, you should write a cookbook next. And, but then I started going around traveling, talking about the book, and I started going to these places and finding out there were pockets. I mean, they're few and far between, they're outliers, but they were places where really cool things was happening. And it wasn't in New York City, it was Hickory, North Carolina, a distressed furniture town. that also had a ton of pill mill clinics. And where I see two things. One is like a new approach to criminal justice, but first I want to talk about harm reduction. I followed this group called Olive Branch Ministry, which is all over Western North Carolina, and they started doing needle exchange before it was legal.
Can I just break in and have you tell people what harm reduction is?
Sure. Harm reduction is this idea of going to people where they are and bathing them with social supports and non-judgment. And it often is the same as a needle exchange, whether it be mobile or in a bricks and mortar. And we know that people who use harm reduction services are 5 times more likely eventually to enter care. I mean, the research is going back to AIDS, HIV, it's very clear. But it's really hard sell in some rural communities, which have been hurt the longest and have the fewest resources to fight back.
Because the idea is not to urge treatment and have that be your immediate main focus. It's to work on things just to keep people alive while they're using it.
Right. So my new book begins next to a dumpster in a McDonald's parking lot, where a nurse practitioner who's worked at a federally qualified health center all day long, at night volunteers for harm reduction. And he's starting to do low barrier buprenorphine. That's the medication assisted therapy the doctor was mentioning, and which we know is the gold standard of care, but which most doctors still don't prescribe, even though they got rid of the waiver last year.
Right, so anybody can do it.
Yeah, anybody can do it.
You don't have
but
to
if
go
you
through
don't
onerous training.
Yeah, and you don't want those people in your waiting room, there's still a lot of stigma even among the healthcare profession. So this nurse practitioner is meeting a new patient. He shows up high, he's late, he's crying. He says, if I don't get off the needle, I'm gonna die. And Tim is going to write him a discount prescription for Bupe that he'll pick up at this one Walgreens where they prearranged the next day. But he wants him to know 2 things. And I think these are really the keys to turning this back, because this is the largest group of folks who are still using, don't think they can stop, don't want to stop. They've been stigmatized for years. And he says 2 things. One, you can get better. Like, most of America has written this population off. And most of them have written themselves off, right? And then 2 is, don't disappear. That means even if you return to use, which is highly likely, we know it's a chronic relapsing disease, still come to my appointment next week. And if you can't come, I can come to you if you text me.
Right.
And it's just this kind of, I mean, it was so cool to follow him because he starts treating people's hepatitis C, which they don't know they have. Then people who get better start hosting hepatitis C testing pizza parties in their homes. And it's like that old-fashioned Eugene Smith photo of the country doctor, really doing that. And we know that works. And the women who run this, they're a married couple. It's called Olive Branch Ministry. They have matching tattoos that say acta non verba, which is Latin for do shit, don't just talk about it. Right? And so that whole thing, like getting out there and making connections, is really what I'm seeing working. Another place I just want to talk about really quick that I profile in the new book is Fairfax, Virginia, which is an urban center. It's the largest county in Virginia. But just to show you, sheriffs have so much power in terms of how they handle this, whether it's a criminal act, a moral failure versus healthcare. Well, at the Fairfax County Jail, the sheriff partnered with the harm reduction group, and every person that now comes into the jail gets screened for OUD or SUD, substance use disorders. They get offered buprenorphine if they want it. They get counseling. And then the most important thing is they bring in people in recovery who are called peer support specialists to work with them. So at the moment when they're released, which is when they're most vulnerable to overdose and death, they have somebody pick them up, with Narcan, with an MAT prescription, and take them to the next place they're supposed to go. And so that is like really trying to close that gap where people are dying so much.
Wow.
But it was a tough sell because she's an elected official, and she had to bring in all these trainers, and the deputies said, what? We're letting these peers, i.e. they're all felons,
Yep.
we're giving them a badge to the jail. We are giving them buprenorphine when some of them are in the jail because they've been illicitly selling buprenorphine. And then she had to make that courageous decision of letting people go who wouldn't follow the program. And they've had amazing results. But that issue of harm reduction can be, as you know,
it takes courage, right? And on that topic of harm reduction, part of it to me that's so important that we don't really talk about as much is that harm reduction addresses some of the awful, things that go along with chronic drug use. Oh my gosh, I'm blanking. The heart issue.
Endocarditis.
Endocarditis. Yeah. Horrible wounds from injecting,
yes.
et cetera. Harm reduction can go so far in preventing deaths of despair from these adjacent to drug use things. Are you seeing success with that here in Chicago, Dr. Ezike?
So we have 2 hospital ERs, one on the southwest side of Chicago, not too far from here, Holy Cross, and then we have our flagship hospital, Mount Sinai, on the west side. And so, we have 2 of the busiest ERs, in the city and the state. Mm-hmm. And so we see all kinds of things. At Mount Sinai, we are across from the beautiful Douglas Park, and we do see that as a regular occurrence, people being brought in with acute overdose. And so after hopefully after you're able to bring them back, then you're, attending to these other issues, doing, skin screens and just trying to make sure that
right.
things. But
hepatitis screens, seeing if you can treat that.
Yeah, but ideally you really want to make sure that people get into care, right? They need a primary care physician. You need some of these really loving type of non-judgmental, culturally competent individuals that can build that relationship and so that you can address all these other needs. It's really making sure that you have, that next warm handoff mm-hmm. that can ensure okay, yeah, we brought you back, we can even give you Narcan, but it's an ongoing journey. And so you need an ongoing partner to really make it through those additional steps.
How much are you intentionally including, emphasizing the importance of that non-judgmental approach when you hire primary care doctors and train them and encourage them to work with addicted patients or patients, seeking treatment? How much of it is it part of the conversation for primary care in particular these days?
I think it has to start, it starts with your mom and dad, right? We need to not be judging one another, and we need to have empathy, and we need to care for one another, and we need to look out for our neighbors. But, it's really, at the medical school level, it's every single level. At medical school, there have to be more courses that are talking about that interpersonal relationship and how to be able to help someone, be curious, be caring, non-judgmental. You want that to continue on in your residency training. By the time you're coming to a hospital for your job, you hopefully have those skills already. But it is something that's continually emphasized. We have a lot of things that we need for the populations that we serve because, we know that there's a lot of, unconscious or conscious bias, whether it's because of race, anti-Black bias and anti-Black racism is alive and well, in case you weren't aware, against other groups, against LGBTQ. So we need everyone to be thinking about all these groups. And so we have regular trainings, we have regular management meeting discussions. Every one of my meetings, I have an equity spotlight where we're talking about these different opportunities that we have to look inside ourselves and see what biases we hold and what are we doing actively to move forward, because we all have them. We all have our issues, and if we're not confronting them with ourselves, we're never going to advance the needle.
Really smart. I'm wondering if any of you have thoughts on whether it's at all easier to advance solutions and to get your arms around the problem of deaths of despair in rural versus urban areas. Are there benefits to either type of place, or is it really just kind of the same problems, the same solutions? Does either place have a head start in any sort of way? Dale?
I can't speak to the big city part, but as far as small towns go, I think we have a distinct advantage because, and it's been said before, there's a tribal, neighborly, compassionate thing in a small town that I'm not for sure how that transitions over to big cities, but and there's a really good feeling of ownership. And Sarah said it yesterday about feeling defensive about saying where you're from if you're from a small town. Being from Portsmouth, that really resonated with me, but then it was like, we're now going to go on the offensive because we're tired of this, we're tired of what media portrays us as, when we're going to rewrite the narrative. And so, and we're not going to, we have a saying in the gym, it's like, no one's coming to save us, it's up to us. And I feel, that's a really solid sentiment where we live, but I feel that could be anywhere because all big cities are nothing but a fabric of neighborhoods.
Yeah.
And it just takes it takes leadership within those to stand up and say, I've had enough.
Yeah.
And I'm willing to do something about it.
Have any of you seen religion play an important role in solutions? I'm curious, anywhere, or do you feel like being part of a religion, part of a religious community, gives you a leg up, or no? Is it really just that's one way of having community, and it's community that counts?
I think it depends on the place, but you and I have both written about Dr. Steve Lloyd.
Yes.
Who we both love. He's a treatment provider in rural East Tennessee, and he himself was addicted to OxyContin, and the Michael Keaton character in the Dopesick Hulu show is loosely based on his story.
Does a great job playing him.
Yeah, he really does, but he tells the story that I use in Dopesick where he's trying to convince this rural community in East Tennessee to open a methadone clinic. And it's right down the road from where he grew up. And he said and they're filming him to intimidate him. They're all these just myths about how people are gonna run into the school bus when they come out from being dosed with methadone. And Steve throws their religion back in their face because he gets so upset. Finally, a woman in the crowd says, how many chances are we supposed to give these people? Mm-hmm. And he answers with what Jesus said to the disciple when they said, how many times should a sinner be forgiven? Should he be forgiven 7 times or 70 times? And Steve said, 70 times 7, which is like as long as it takes, right? And so I really see people like Steve and Michelle at Olive Branch taking that message and carrying it forward with what they and I believe is real Christianity. And the book Raising Lazarus is called that because Michelle was at a meeting and a woman tried to hijack the meeting where the idea is because it's rural and they lack transportation to get to their clinic and counseling appointments, these churches were going to provide a volunteer network to drive folks to their treatment. And a woman hijacked the meeting. She was the Kiwanis Club president. And she said, I think when they overdose, we should let them die and take their organs.
Oh, wow.
And Michelle stood up and she said, y'all, have you heard the song, They Will Know We Are Christians by Our Love? And I'm not feeling the love. Have you thought about taking your neighbors who are drug users a casserole? Because sometimes they forget to eat.
Yeah.
I mean, she started giving them these ideas, and then she told the story of Lazarus, who, Jesus was late to revive him. He's dead for 3 or 4 days, and he performs the miracle, but it's up to the disciples to do the hard work on the ground. They have to roll the stone, they have to bring him out, unbind him from his burial cloth. And what she says is, it's messy work, dealing with people with the OUD, and you might get a little something on you, And only by experiencing that work on the ground will you get to feel the miracle of raising Lazarus. And I think that's really powerful, because when you see people starting to change their minds about, these are real people, these are our neighbors, this is my cousin who works at Subway who is like in jail for selling a user amount of dope when Richard Sackler walks free still. Like, that's how we start to get the messages across. But I'm so frustrated because I've been reporting on this for over a decade now, and it just doesn't feel like we're moving the needle.
And I'm going to take off my, president of a health system hat and my, believer hat. Like at our church, we do have a Celebrate Recovery group. And so we have people that come every Monday that are coming, to be supported, to pray. And they say, because they'll give the testimonials, that it has been so helpful. And again, it does come back to community and having people who are going through the same struggle. And there's also something about being able to give something up to something bigger than yourself, and to not feel that it's all on you, that there's another source of strength. So some people get that, through, any type of organized religion, sometimes even through meditation or focusing on stars. But really, like, for people who use religion, having a higher power to reach out to is a source of strength. And it's also very powerful for other people in that religious body to understand that we all run into things, but still can overcome them, and can overcome them maybe with the power of another God that you profess to. So it's a growing experience for everyone.
It seems with the opioid addiction in particular, it's important to walk the line. If the higher power approach is important to you and works for you, to also accept the evidence-based treatment and find a way to mesh them, rather than have them be at odds with each other.
No, they don't have to be an exclusion.
Because there has been a lot of fighting between the two, the medication approach and the 12 steps approach. But I do think that people can work successfully with both.
Well, and they should. They should be measured by their effectiveness.
Right. Well, yes.
Yeah. And this is, it goes rural, like we're red, blue, rural, urban, MAT, non-MAT. Not a lot of people really, there's a lot of people who believe in both. Like, use MAT as a bridge to reclaim your health and as a way to long-term recovery.
Right.
They don't need to be either or.
Right. They don't need to be in opposition.
I see harm reduction as the way to get people into MAT too.
Yep.
So it's a continuum.
Right. There's so many things I still want to ask, and I see our time is going to run out before too long. Dr. Ezike, I wanted to bring attention to this study that came out in the medical journal JAMA this week, pointing out something that the three of you, I'm sure, know well already, but that the mortality rate among Black Americans at this point is exceeding the mortality rate among white Americans in these deaths of despair, and particularly in overdose deaths. And I feel like we don't talk about it enough. Those of us who follow addiction and treatment and the whole issue. And I'm wondering if you have any thoughts on the role that health disparities and economic disparities in general are playing in this, and if you have any hopeful notes to bring to the idea that we're seeing so many Black Americans now dying, when in the beginning we really weren't 10 years ago.
Yeah, I think there needs to be like an understanding that people who are in vulnerable situations are going to have the most dire effects of anything that's put upon, right? We saw in COVID, the people who were most vulnerable were people in under-resourced, underserved communities, concentrated poverty zones, if you will, which is very similar to the communities that we serve at Sinai. And so understanding that those, that's like saying, if you have a house that wasn't built with the right materials to be, fire retardant, and there's a fire rushing through, like you don't sprinkle water equally on every house. You need to go to the house that you know is going to be in trouble. And so understanding ahead of time who the vulnerable people are, and unfortunately, and I would put a lot of this on, like just an origin, like just a foundation of racism in this country that has led, to a higher rate of impoverishedness in certain communities. The communities that we serve, that those poor communities are, that's directly related to, housing discriminatory policies that resulted in people not being able to either live where they wanted to live or be able to have a loan to buy a home and have that wealth accumulation and pass it on. And so you have generations of poverty, and that sets you up to be most vulnerable when something like, an epidemic, a pandemic, something comes through. And so understanding that we need to support, quote, the least of us, support those who you should know ahead of time who's most vulnerable and be able to address that. If we don't go to the communities that are most vulnerable, it's not a big surprise that African American communities are seeing the highest rates. We're seeing that for cancer, we're seeing that for diabetes, we're seeing that for every condition. And so being able to be more targeted and have more outreach and more support. I know when I was the public health director, you wanted to get vaccines once they were available to everyone, and the plan was to do them through the pharmacies. Well, guess what? The pharmacies are not, like every 3 miles, there'll be a pharmacy. Like they're concentrated in certain neighborhoods, and then they're less concentrated in the poorer, under-resourced communities where a lot of Black and brown people live. And so being able to be aware of that and say, oh, okay, state, we are going to come in and fill in those gaps. We need to fill in those gaps because the people who might need it most have the least access. And so that's at the heart of, health equity, identifying those at-risk populations and doing more, not the same amount, not less, but actually more
really
to be able to, intentionality is really key.
Before we move to audience questions, Beth, I am so haunted by what you said at the beginning about how mental health crises are now almost eclipsing. Were you talking about EMS calls in your hometown? Eclipsing, overdose calls. And I think that's familiar to all of us. This mental health crisis that's going on among kids, teenagers, everybody, since the pandemic especially. And I'm just wondering, how much is that part of your new project? And tell us a little about your new project and whether mental health factors in.
Yeah, so the idea is I'm doing a partial memoir about growing up poor in a small town in Ohio, and I'm going back 40 years later to say, how has it changed? And what is it like for a poor kid now to get out of poverty? And this kid I'm following was the high school band drum major while being homeless his junior and senior year. Lost a dad to overdose death, mom in and out of prison. And so I'm kind of following the travails of him who got a double scholarship to a community college, but it's an hour away from where he lives. And he's now on his 5th car for this year to get his welding certificate. And it's just been so eye-opening to see, like the teachers in the schools are really they are the lifelines for these kids. Like the band director was with him every lunch period, and you really have these kind of heroic people on the ground, but the leaders kind of not doing much, not doing, I really think every school should have a health clinic, whether it's a partnership with an FQHC. In my hometown of Urbana, they just opened an FQHC in the town that's a federally qualified health center. More than half of all the appointments are mental health, and there's a 6-month waiting list for counseling, although they save 2 openings every week for suicidal calls. And if 2 openings, and if a kid will sometimes go to the emergency room and spend 7 days there waiting for a bed to open up in Columbus, the capital city. So it's just really urgent, but there's no press there. And when I go home, I spend a week there every month. I'll tell my friends who are leaders in the community now what I'm seeing, and they have no idea. Like, they don't even know what the problems are.
Right.
Because they have nobody reporting on that.
Right. I think the mental health issue is our next, piece of deaths of despair that we really need to plunge into and figure out. And it sounds like your project will go some way toward doing that. Sorry, I'm a little late, but we're opening up to questions now. And we'll start with you over here.
Hi there. My name is Garrett Simmons, and I'm here with Wilmington College, but I hail from the town of Chillicothe, Ohio. And I have a question especially for my fellow Ohioans. How do we go about planting the seeds of conversation with the people in our communities to, find these community-based solutions to the opioid crisis, especially when there is so much stigma in the communities and even within our healthcare systems?
One thing we started doing is we invited cops and those in addiction to come to the gym and work out together.
That's a great idea.
And we put them on a team. And I say, who here has been arrested? Half the room, hands up. Who here's ever arrested somebody? The other half goes up. I'm like, all right, you guys are on a team together. We do a workout, and like I said before, afterwards, in a way, my guys are in good shape, so they really take it out on the cops when they're working out.
They're in better shape.
They're in better shape. Anyway, so we sit around and we say, hey, would anybody like to, here's the floor, tell your story. And that's very popular in recovery communities. But what happens is cops are more willing to tell their stories. And I'll never forget, we just did one and a police officer was just like, guys, I don't want to come get you. I just want to help you. My sister died of an overdose. And we go back and we talk in mental health. Yeah, we're talking addiction here, but I've seen more people die in my hometown than I did in Iraq.
Wow.
Cops are going on calls every week and witnessing death.
Yeah.
Social workers, nurses, firefighters.
Often in people they know.
Yeah, classmates.
And that, you build up a massive callus to what you see, and you begin to go back and forth and blame the other side. But it's just simple things like that.
Understanding each other.
Tell about that judge in Charles County,
Yeah,
Virginia.
so Judge Lee Harrell, Circuit County Judge in rural Virginia, he came and visited us, and he's like, I don't even like to call my court drug court. We call it recovery court. And then what he does is 2 nights a week, he literally turns the courtroom into a gym. And so he invites everybody in his program, and they do team workouts together. It's insane to see like an actual courtroom turn into a gym. But he's like, and he used to be a prosecutor, and his job was locking all those guys up. And he had a big come to Jesus moment, like, this shit ain't working. And maybe we should figure out a different way, and maybe start with compassion. And he's been a big hero of mine for doing
I'm going to call that an out-of-the-box, community-based approach. Sounds really amazing. Yes, over here.
Hi, my name is Toyib. So from the University of Vermont, my question is that I'm wondering if we have like perspective from the policy side, people who have had to deal with this issue from a policy point of view. What is like the challenges they are facing, and what does sustainable solution look like from a policy point of view? Thank you.
Yeah, there's many points that could be brought up. Obviously, a lot of the decisions in terms of what is paid for, insurance, coverage, that's significant. Understanding what the laws will be in terms of dealing with individuals. Are we going to do the compassionate approach? Are we going to do the criminalization approach? Like that's really in the legislators' hands. And so advocacy for the kinds of policies that will help people really, be able to optimize their life and have, those additional chances. Like that's ideally what you would want. And of course, the funds to be able to provide not just the medical services, but all these wraparound services. If people were not unhoused and hungry and jobless, like some of that is a positive buffer against some of these diseases of despair. So making sure that we are active on all fronts. It's not like, what do I do first? We got to do everything at once, multi-pronged solution. And we do need our legislators to be functional and get some of that done.
And making sure that they're not running away from policy solutions because of politics. Yes.
Hi, my name's Hallie Lovin. I'm a master's student here at the University of Chicago at the Harris School of Public Policy. My question surrounds this idea of harm reduction, and specifically one facet of that being supervised injection sites. How can we combat negative stereotypes that surround ideas like misconceptions that they're making our communities dangerous, more dangerous, and that we should actually be incarcerating these people? What are some ideas that you have for that?
Yeah. Brown University just did a study of the overdose prevention sites in New York City and proved, like with data, that it didn't cause crime to go up. And I think you're hearing a lot about sort of the failures in Oregon now, and this idea that
the destigmatization did not work.
yes, because they launched into decrim before they had all the health services in place and the connections to care. That doesn't mean we should throw the whole thing out, I think, because I think criminalizing it does a lot more harm.
And how many safe injection sites are there around the country now, Beth?
There's just the 2 in New York City. I think Rhode Island actually has a pilot. I'm not sure if it's open yet.
We're still just talking 3.
Yeah, we're just starting it. My fear is that what's happened in Oregon and how they reverse that is going to hurt the other. And I really think Sam Rivera is a hero. He's the one that started the ones in New York City. And, you know, they've had 0 deaths. They've had all kinds of connections to care. And as the Brown researchers show, it really didn't create a uptick in crime.
Let's see over here.
Yeah, hi. Oh, wow. Okay. Hi, my name is Louis Weiss. I'm from the University of Cincinnati. I'm here with the Portman Center for Bipartisan Policy Solutions. I'm actually originally from Youngstown, so we deal a lot with this type of issue there. And my question for you is, what do you think the next steps for transitioning addiction care within the criminal justice system from incarceration to recovery is, especially as the incarceration system has become a hub for addiction since the 80s, and noting the racialized aspect of this?
Great question.
That's a great question. I mean, coming out of incarceration is the most dangerous time. It's the most dangerous time for anyone with substance abuse because all of the tolerance is gone, right? So if you were using, you had a certain amount that, you know, although it's hard now because things end up being laced with other things that you weren't really anticipating. But once you are incarcerated, assuming you weren't on a steady dose, on a steady regimen, and so coming out, you know, if you were to go straight to, you know, that next score, that could be a fatal, like you're just, you don't have the tolerance for that. And so, you know, even here in Cook County, you know, whether people are coming out of Cook County Jail or at the state prisons, you know, they really try to have that warm handoff right away, connecting people to care, having people leave with Narcan, lots of education and training, trying to really bridge people so that they're not free and then all of a sudden, you know, some fatal outcome. But that needs to be, you know, systematized throughout because it's such a vulnerable time.
Mm-hmm. And you've got some states that have really embraced that, and like Rhode Island.
Rhode Island.
And you probably wrote about that, didn't you? Yeah. So you saw, like, I think they brought in methadone vans.
Yeah.
And people would get dosed.
And they had tremendous success.
Yeah. And I think a lot of the key is like building up this peer support systems so that, I mean, I've seen peers do everything from taking people to sober living to babysitting a drug dealer's dog because that's what needed to happen that day for this person to get into treatment. And I call them my rowdy angels because, and just hearing more stories of people in recovery, I think can be really helpful. I mean, as you know, so powerful.
We started doing classes inside of correctional facilities, essentially low or nonviolent drug offenders. And now so we go to the prison, we'll do the class, and now they know, depending on where they are released to, they know that, hey, this treatment facility offers the same class. And then eventually, the state of Ohio actually is going to, across 30 different correctional facilities, offer these classes because they've seen the value that fitness, community fitness can bring to those folks. In addition, the long-term goal is now we can, for those who are interested, either they become peer support specialists or they become trainers who can go right back to the prison and earn a wage offering those classes as well. So there's programs like that really need to be evaluated and explored as well.
Thank you.
So you just need to scoop up folks from red states and blue states and get them in a gym together to do CrossFit.
You've explained my life work,
Yeah, I just love it. We have time for one more question.
Hello, my name is Asami Takagi. I'm a medical student from Central Michigan University, and for context, the medical school focuses on underserved communities, specifically serving rural Michigan. Some of the ways that we've tried to incorporate the topics here is through getting a management, treatment, diagnosis certification in opioid use disorder for all students, and making sure we have a day working in the clinic. We also have the DEI workshops, as many medical schools do, but I am just curious if you guys have any suggestions about how to incorporate other workshops and other curriculum into medical school curriculum so that it's more effective, so that future physicians can kind of have a jump start that other physicians may have not had previously.
Yeah, so being in state government previously, there are the Illinois Department of Professional Regulation, IDPFR, so they give the licenses, to physicians in all professions. And so, being able to affect, what are the requirements? Sometimes there'll be a new requirement, that said, okay, MAT training has to happen. Sexual abuse training has to be done, like really working with advocacy groups to figure out what are the next things that need to be added to requirements. But at the medical school level, I think that's a little bit maybe easier where people, schools, deans have the opportunity to have different courses offered, once they realize like, oh, maybe this is something important, then it could be standardized. So really just staying active, with the leadership, identifying where we think there's the most need in terms of, strengthening up the future doctors of tomorrow, and congratulations on being one of them. There's a lot of opportunity. And I think even before things are official, just getting people together and saying, I think this is something we need, and seeking out the person who can provide that, and then building that buzz and that groundswell. A lot of things that we do now are because, activist students were helping to push. If it's not already something that's happening in the community that you can join on, but I know it's a lot to put on a student. You guys are really busy. I was there, but good things don't happen without these important pushes. And so I'm glad to see that you guys are getting some of those pieces of education at this time.
Yeah, we're still, as taxpayers, spending millions of dollars creating, funding residency programs in med schools that are still turning out doctors that don't really know how to recognize addiction and treat. I had these two young friends recently graduated from Harvard Med, and they took a 9-hour board exam, 2 questions on addiction in 9 hours, when deaths of despair, the number one cause of death for people 25 to 49. So it's almost like we should redo the whole curriculum around deaths of despair.
Completely. This was a recent exam?
Yeah, it's a year ago. They were these two they just got married, and they went to open a medical clinic for Brian Stevenson at the EJI in Montgomery for people coming out of jail. Because because they are the activists you were talking about.
Yes. I think that point about activists could not be smarter. Thank you all. Thanks to the 3 of you so much for the excellent probing work you do.
If I may, we talked about awareness, and we just released a documentary a few months ago, aptly enough, called Small Town Strong, and it documents the work that we're doing in Portsmouth. So I invite you guys to check that out.
Awesome. Is that on Netflix?
It's on Amazon Prime.
Amazon Prime. Cool. Great. Thank you, everyone.
Thanks, Abby.
Thank you.